Welcome to our session this evening. We're going to be talking about papillary breast lesions, and we're glad you could be with us. So I'm going to talk about some of the breast papillary lesions. And I've got a little presentation and a number of digital slides we can go through to talk about these cases. So this will sort of be discussion. I think some of you got to look at the cases beforehand, but the most prominent or popular lesion, of course, is just the intraductal papilloma, which is fairly common. It's benign. Women of various ages can have this problem. And this is proliferation of epithelial cells that have a fibrovascular core and some underlying myoepithelial cells. So those three things are very helpful to see and suggest that that's the most likely lesion. And I don't know how they do it in your hospital, but it would be very interesting to know. In our hospital, if we see one of these lesions on a biopsy, then typically, or needle biopsy, then typically they will resect the area of the lesion to get better margins, to get better control, and to further evaluate her risk. But in reality, the difference between that resection and the needle biopsy, if there's no atypia, it's very rare for there to be a change of diagnosis. On the other hand, if you see atypia in the epithelium, then up to 40% or more of those cases will end up getting upgraded to a more serious lesion. And we'll show some examples of that in the slides that we look at. Now, it's also interesting to note, and this is part of the reason why they resect these lesions, is that there is some risk of subsequent carcinoma, even with these benign lesions. Probably not directly from the lesion, but the lesion, the intraductal papilloma, is a marker of epithelial proliferation and therefore of risk of developing cancer in a woman. So let's look at some digital slide examples.
Professor, can you open the transcript?
Thank you. Very good reminder. Let me do that. And here's another person joining us here. And live transcript. Okay. Now we should be able to see the transcript, and you can understand me a little bit better. All right, so here's a classic needle core biopsy of a lesion that was probably a BI-RADS 4 type of lesion, a little bit of solid, a little proliferation. And at low magnification, we can see that there's some blue and a fair bit of pink tissue. Now, interestingly, we don't always see these as being highly papillary. This lesion has very solid areas, in fact. But we do see this telltale sclerosis that sometimes we see in these papillary lesions. And we can see that there's some fairly mixed type of epithelium here. We see some histiocytes here in this papillae, and as you can look at this papillae, you can see that there are really two cell populations lining this. You see these cuboidal to columnar cells on the surface, and then we see some nuclei underneath that are the myoepithelial cells. So what's going on over here? Well, there can be some associated ductal hyperplasia with these lesions as well. And this is where the question of atypia comes in. This is a very jumbled type of hyperplasia here, cells streaming in all sorts of different directions, and little slit-like spaces. So this is more in the usual ductal hyperplasia category than in the atypia category. But you can imagine potentially being concerned about solid areas like this, where you have no evidence of a fibrovascular core. In a case like this, you might be well served to consider doing estrogen receptor staining and also CK5-6. Those are useful markers to distinguish hyperplasia of the usual type from ductal carcinoma in situ. In ductal carcinoma in situ, it shows very strong, intense clonal positivity, and the cells tend to be negative for CK5-6. Whereas in usual hyperplasia, they'll be positive with CK5-6 and have a more heterogeneous pattern of staining with ER. Now, we also want to look in these situations at the periphery of the lesion to see if there's any evidence of proliferation. And this is why these lesions sometimes are excised, is because you see areas like this where you could almost wonder about invasion. Again, I think we probably do have two cell populations here. And if we did a myoepithelial marker like P63, we would probably see that light up in this case quite nicely. So sclerosis, sometimes solid areas can occur in these papillary lesions. So this is not quite a classic case, but we'll have several other examples here we can look at. Here's something that may be a little bit more classic, and we see this in a couple of ways here. And this illustrates another presentation of these lesions on biopsy. So the first is that sometimes these lesions will present just as loose floating fragments. And as we look at this fragment here, we can see that it's got this complex papillary-like architecture with a lot of loose fibrovascular tissue forming the core, and then the lining epithelium that we've indicated with a couple of cell types. Now, sometimes, as you see here, the cytology can be a little bit concerning. So we see some nucleoli in these epithelial cells. We do have abundant cytoplasm, but it's sort of puffing up, maybe a little apocrine-like with these little tufts off the surface, like this. And so would you call this a intraductal papilloma or a papillary lesion with atypia? I think some people might. I'm not sure I would at this stage, but because I don't have to worry about that too much, because in my institution, if I call it a papillary lesion or likely intraductal papilloma, I know that they're going to resect that patient if she's a reasonable surgical risk, which is most patients with these lesions can be managed with a local anesthetic. They don't need a general anesthetic. Now, the other thing we see in this sample, in this biopsy, is we actually do have the area where we can see it inside the duct. Yeah, let's come over here. Well, maybe I'm on the wrong piece. Ah, yes, there it is, hiding up at the top of the screen. So here we see the nice ductal space and a similar fragment floating in the lining with maybe just a focal connection to the wall. So this makes that diagnosis more certain. We can say that this is an intraductal papilloma, whereas if we just had the floating fragment, we would say, you know, papillary tissue consistent with or suggesting a intraductal papilloma. Now, again, in this circumstance, if we did a myoepithelial cell, we would see that those cells lining this large cystic space, but we'd also see them inside this lesion along the fibrovascular cores and beneath the epithelium. So this is a composite proliferation of the epithelium, the myoepithelial cells, and the stroma, all proliferating in conjunction with each other, rather than just an epithelial proliferation or a myoepithelial proliferation in isolation. Let's look at another case. So here's another needle biopsy, and I assume that if you see needle biopsies in your institution, you have the same challenges that we do, where these can be very focal, maybe just on 1 or 2 levels, and maybe just a small area of the tissue. So here we have this lesion, which has this sort of hyaline fibrotic tissue with a lining and then an internal proliferation of, you know, small papillae. Likely there's a fibrovascular core in a few of these, but it's pretty hard to tell. And so again, in our institution, this would usually lead to a slightly larger excision to more fully evaluate the lesion that they've identified through radiographic screening, mammographic screening, and so forth. The other feature here to suggest that is we see this surface lining. This is probably not the edge of the biopsy. The biopsy went through this, but it broke the cyst apart. And so while this could be just simple cystic change, the fact that we have, you know, a little bit of free-floating epithelium and these little papillary areas over here fits better with a papillary lesion, likely an intraductal papilloma. And that's really all we get. Now, in terms of managing these samples, what's the best way to manage a breast needle core biopsy in terms of answering the questions that may need to be answered? I will tell you what we instruct our histology laboratory to do is to cut 7 levels. And then they will take the first level and the 4th level and the 7th level, and they will stain those with H&E. And we will look at those, and that means that we have at least 2 levels in between those other stains. So then if we have a cancer, we have some unstained slides that we can be fairly confident have the lesion in them to use for prognostic markers like HER2, ERPR, maybe Ki67 if you want to use that. So that's the way we manage the specimens. You could do 9 levels. There's nothing wrong with or magic about 7. Some places do 9, and then they'll stain, you know, 1, 5, and 9, or 1, 4, and 7, something like that, to get a better idea of kind of how thick or how big your lesion is, and save useful tissue for your markers. Okay, well, that was a little aside here. Let's look at another case. Here again, we see a needle core biopsy sample, cystic space, another cystic space, some hemorrhage, and then a little bit of blue tissue kind of floating off here in the middle of one of these cystic spaces. So again, we see a degree of sclerosis or hyalinization, but we also see some fairly dense cellular areas. And this illustrates some of the changes that you can begin to see that make it a little more complex sometimes. And that is, we're beginning to get an apocrine metaplasia here. And so like other areas of the breast, sclerosing adenosis or intraductal papillomas can develop apocrine metaplasia that can make it a little bit more complicated to discern for sure that it's a papilloma. But we do have this nice fibrovascular core out here. It's not a pure population. One of the problems with these apocrine metaplastic lesions is that the number of myoepithelial cells you might be able to demonstrate will be probably much lower. And you may only see 1 or 2 or 3 or, in a few areas, because the amount of stroma and basal lamina that you have to support the myoepithelial cells is limited. So I would report this as, papillary ductal proliferation with apocrine metaplasia, most consistent with intraductal papilloma, but that would lead to further resection in most cases, or very close follow-up to watch what's going on with the patients. So this is a good question, how to distinguish intraductal papilloma from papillary DCIS. And we're going to talk about that. I've got some nice illustrations, but primarily it is the degree of cytologic atypia, and as we've indicated, the staining pattern can be very helpful. So using hormone receptor like estrogen receptor, using CK5/6 can be very helpful in identifying the DCIS-like pattern. DCIS tends to stain with a very strong so-called clonal pattern of estrogen receptor staining that is very helpful diagnostically, and of course indicates that these are hormone-sensitive lesions that are proliferating in the breast and responding to the hormonal status of the patient. All right, let's look at another case. Here's again another example, small area of blue staining, but we see other sort of evidence of macrocystic spaces that may or may not have held epithelial neoplasia or proliferation. Again, we'll look at this and just take a peek at the cytology and the architecture. Here again, we see nice fibrovascular cores, and the papillae have this sort of outward columnar cell pattern, not at the apocrine metaplastic change that we saw in the previous case. And I think you can use your immunohistochemical eyes and see that there are some basal cells here that are likely positive myoepithelial markers. If we look really closely at the cytology on these, there's not a high degree of atypia here in this case. And so this would be the sort that I think be very unlikely for this to be upgraded to papilloma with atypia or DCIS in this setting. Now, that's not to say that there can't be DCIS associated with papillomas that are not atypical, because as we see, even areas like this, there's sort of a more pure epithelial proliferation here. And so there can be variability within the papilloma that can range to some degree between no atypia and potentially even DCIS. So I think that's the rationale where people say, well, all of them should be resected to exclude that possibility. All right, one last example of intraductal papilloma, this one with a very pronounced degree of sclerosis, and as you can see, calcifications. Now, this papilloma is nearly solid in terms of the epithelial proliferation, and we get very minimal evidence of a fibrovascular core other than the sclerosis. And so these lesions can sometimes create problems in terms of terminology. Why would we call it a papilloma? Because we don't really see papillae. The name is entrenched in the literature, and this pattern of dense hyaline sclerosis plus or minus the calcification has been termed a sclerosing intraductal papilloma for longer than I've been alive, and I'm not going to try to change it, but that's what they look like. And again, they're going to be picked up by the X-ray, by the mammogram, although I think these calcifications would not be highly suspect on mammography. They'd be so coarse and chunky that they would usually think of these as being a fibroadenomatous type or sclerosis type of calcification rather than the punctate grains of sand that are more common with ductal carcinoma in situ. So the differential diagnosis for these papillary lesions includes all of the following. Now, some of these are very common. Atypical ductal hyperplasia is quite common. And some of them are so unusual that I haven't seen them. You might see them. The more common ones are the so-called interductal papillary carcinomas, which is to be contrasted with encapsulated papillary carcinoma. So this would be a papilloma where you can identify papilloma, but there is an associated component of DCIS. And then these encapsulated papillary carcinomas are typically large, dilated, cystic structures or encapsulated structures where you have a more pure proliferation of low-grade papillary carcinoma. The remainder of these, the invasive component, adenomyoepithelioma and so forth, solid papillary carcinoma, these are quite rare lesions and not very frequently seen. The adenomyoepithelioma may be more frequent. But I don't have a good example of that to share with you, so it may be less frequent. So let's take a look at one of these. So here's obviously a proliferation, and we can see there's sort of an intraluminal proliferation here, and a little bit more papillarity here and here, associated with inflammation and some calcifications. If we go here to this first one here, I think you'll see pretty clearly at this magnification that this is, forming kind of Roman bridges. It's got punched out spaces. It doesn't seem to have fibrovascular cores, and it's got these calcifications. So even at this magnification, I'm thinking this is more the pattern of DCIS than of intraductal papilloma. So this is, in fact, what that is. We can see a degree of monotony out to these cells. They're not highly atypical, but the architecture is certainly altered from what we would see with usual intraductal papilloma. And here again, we see that change. Now, there may be a little bit of sort of residual normal cells, but you see these cells become a little rounder. They're quite homogeneous. You get small nucleoli and the calcifications associated with that. And we can see that in several of these areas. The inflammation also is helpful here to suggest that this is a potentially antigenically stimulating lesion that's causing an inflammatory response to the lesion. So this is a slightly papillary pattern of ductal carcinoma in situ with some cribriform areas and some papillary areas in some portions of the lesion. Let's see, was there anything more here? Oh, we'll look at this other piece over here where there's maybe a little bit more papillarity. So you can see that, this looks like a little papillae here, but it's really part of this Roman bridge formation. Here's some irregular branches across. Now, the differential between, atypical ductal hyperplasia or even usual ductal hyperplasia, in a case like this, if you're concerned, this is where we would use CK5/6 and estrogen receptor to see and verify that this has the features of ductal carcinoma in situ. That is strong clonal type ER positivity and absence of CK5/6, except in the myoepithelial layer. So it's all at the periphery. So the CK5/6, whereas in usual ductal hyperplasia, the intraluminal component will light up very strongly with CK5/6, and the hormone receptors will be heterogeneous or absent. All right, let's go on to one more case. So papillary ductal carcinoma in situ, as we've indicated, has this in situ pattern, a uniform, fairly low-grade atypia, clonal ER, preserved p63 staining at the periphery, but not along the papillae. There may be calcifications and necrosis, of course, and relatively few or no fibrovascular cores. So that should answer that question that was nicely posed earlier. Let's see, I think we have another example of some of the changes that can be seen here. So here's a nice sort of solid expanding lesion with sort of a cribriform pattern and a degree of papillarity here. We can see a few of these Roman bridge type structures, maybe slightly different cytology between here, the left and the right portions of this lesion. Here we have a much more, cribriform pattern, not the usual pattern of intraductal papilloma. And there's this kind of low-grade atypia, a few nucleoli, and so forth. Now, if this lesion only has P53 or P63, excuse me, at the periphery, then this would be papillary intraductal carcinoma. But if it's all along here, then it may be ductal carcinoma in situ that is populating or replacing the papilloma. Here's again a little bit more apocrine type of change to the cells, much more abundant cytoplasm and more solid proliferation, low-grade nuclear atypia, a few nucleoli, fairly uniform, but these rounded out spaces that would be consistent with DCIS rather than usual hyperplasia. Now, how would you distinguish this from, apocrine metaplasia Well, it doesn't have the same snouting. It has abundant cytoplasm like apocrine cells, but it doesn't have that papillarity or the pattern of apocrine metaplasia. This is more of a DCIS type of pattern. So it's a DCIS with some sort of apocrine type differentiation. Okay, let's continue on here and move to the encapsulated papillary carcinoma. Now, when I was in training, we called this intracystic papillary carcinoma, but the preferred term now is encapsulated. These lesions are usually in postmenopausal women. This is a low-grade tumor in almost all cases, and you have this fibrous capsule, no myoepithelial cells along the papillae, none at the periphery, or maybe only focal peripheral myoepithelial staining. So the amount of myoepithelial cells, in contrast to the papillary DCIS, is considerably diminished or absent. Now, there have been some high-grade versions that have been seen, or high-grade cytologic atypia. In this case, those are best treated as a high-grade invasive breast carcinoma, and they're staged as invasive carcinoma, whereas this lesion is still staged as a ductal carcinoma in situ. And that's kind of what guides its management. It has a very good prognosis, very low risk of dissemination or problems. Okay, let's see. Here's a couple of questions that have come in. So, question about P53. We don't routinely do P53 in breast cancers. And so I'm not really well equipped to answer that question because I just don't have enough experience with P53. We do interpret P63 as evidence, if it's just a very few scattered lesions, as evidence that the lesion is still in situ. So here's a luminal B, a high-risk case with HER2 positive. Will we do in situ hybridization for all HER2 positive cases? So at present, we do not do in situ hybridization for the 3+ cases. If they're 3+, we do not go further and do FISH testing. The question is whether or not we can distinguish the HER2 low cases, which now also can be treated with anti-HER2 therapy. And that's still an evolving issue. That assays were not established to reliably distinguish low levels of expression from no expression. So in that circumstance, that the jury is still developing the guidelines for that question. HER2 positive and overexpression of HER2. That's a good question. Do HER2 positive and overexpression of HER2 have the same meaning? I think in general they do, but this is where the scoring system is more useful. So a HER2 3+, that's clearly a positive. If you're referring to HER2 that is a lower level expression, still positive, but 2+ or 1+, then you should use the term HER2 low rather than HER2 positive. And so on our breast cases, we do not do P53 on all of our breast cases. That can be a marker for the the high-grade triple negatives and so forth. But as we know, it can also be seen in other tumors. So very good questions on that discussion. So let's go forward and talk about encapsulated intracystic papillary carcinoma. And I have this very nice example here where we can see these large spaces, somewhat of a capsule around it, maybe some branching to the lumen or some extension into adjacent spaces, and a very papillary lesion. Now, this architecture at low magnification is fairly typical. And this is the reason why our clinicians like to excise a papillary lesion. If they've gotten little fragments that look like this on their biopsy, they want to come back and excise the rest of it to make sure that we don't have invasive tumor associated with this, and also to make sure that we've perhaps gotten a clear margin on this lesion that's otherwise classified as an in situ carcinoma. So we'll look at some of these spaces here in more detail. And as I just illustrated, these are lesions where we would not find P53 in these fibrovascular cores. We might find it out here at the periphery, a few areas, but in general, we should not be seeing it in these fibrovascular cores. As I was taught, you look at these lesions, and once you identify that they're these, low grade but very monotonous and proliferative neoplastic cells, the question is not to be found. The answer is not found in the center of these lesions, but is the important part is what's going on around it. Is there invasive tumor? Is there a more conventional type of breast cancer? And looking at these sclerosing areas like this, it's oftentimes very difficult to say with any degree of conclusiveness that this is not an invasive pattern. But as I mentioned, these are generally treated and staged as in situ carcinomas if the cytology is still fairly low grade. So we'll just take another look here and maybe look at the capsular lining area here and contrast this lining epithelium with this benign duct nearby. So here we see these cells are quite tall and columnar type of pattern, a little bit of jumbling, still somewhat oriented towards the polarity of the cell. In contrast here, looking at this duct, you can see here we have clearly an epithelial and a myoepithelial type of pattern to these cells with a uniform basement lamina, and the cells are relatively small compared to these neoplastic cells within the intracystic lesion. So comparing them to what's next nearby can also be a very useful clue to your diagnosis. Now, I don't expect that on a resection, any of you would have too much trouble with this diagnosis. But if we just had a needle core of a few of these papillae, it could be more challenging. And this is where your ability to describe what you're seeing is useful, and where immunohistochemistry can be useful, and where communication to the surgeon of what the differential includes, and therefore what their next steps should be, is very important. So if I'm just seeing this type of material on a core biopsy and it's kind of floating free without a wall or whatever, I would say, papillary proliferation and cannot exclude, papillary intracystic carcinoma or other lesions of that sort. And with that differential or that consideration, then the surgeon's going to know, okay, I need to excise this lesion. And it's not just a simple papilloma. And this is why I think in our institution, why that is the pattern. It takes a little bit of the burden off of us in terms of placing too much weight on interpreting the findings of, say, myoepithelial markers on a few papillae in terms of making a big difference that might impact the patient's outcome. Okay. Here's another lesion. This, in contrast, is not an intracystic lesion, but it's obviously a very, very papillary pattern. This doesn't have those fibrovascular cores, but it does have a very papillary pattern, and it's quite monotonous. So we look at these cells, quite fairly uniform cells, and a degree of increased NC ratios or a degree of cytologic atypia. This case ultimately proved to be papillary ductal carcinoma in situ, but as you can see, it has this, papillary pattern fairly similar. And so again, your differential, you'd say on this biopsy, could include, intracystic papillary carcinoma or papillary ductal carcinoma in situ or other types of lesions. With this degree of atypia, though, we'd certainly want to make sure that the lesion was excised. Okay, well, let's talk about some of the things that can come along here. Here's another example of that same process. So here's your needle biopsies, and you can see just these floating islands of tumor cells and tumor nest. And in this case, we've got maybe a little bit more of the cribriforming pattern. So this could be papillary and cribriform carcinoma with large ductal spaces. And probably I would have called this carcinoma based on this pattern of cribriform type spaces. So sometimes I'll use the term at least ductal carcinoma in situ, low grade, or something like that in a situation like this, and mention the histologic patterns that we're seeing, cribriform or papillary and cribriform pattern. Okay, let's push on here a little bit further. I'm going to skip this case. This is very similar to that prior slide, and so we won't spend a lot of time on that. I do want to cover this nice summary of the immunohistochemistry findings in these various differential considerations. And I've mentioned the myoepithelial markers, the hormone receptors, as being very useful. And myoepithelial markers would include things like P63, CK56, calponin potentially, those sorts of things at S100 to a lesser degree. So with the intraductal papilloma, you're going to see positive myoepithelial markers in the outer lining cells and within the papillary lesion. The hormone receptors, this is intended to illustrate a sort of patchy pattern, whereas papillomas with DCIS, this pattern is intended to illustrate a clonal pattern, a very strong, every cell kind of strongly positive, whereas no markers with the myoepithelial cells. Papillary DCIS will have the clonal pattern of hormone markers, and it will have the myoepithelial markers at the periphery. Whereas encapsulated papillary carcinoma, same pattern, but very few or no myoepithelial markers at the periphery. So that's the key difference in these two lesions. Fairly similar behavior, but a subtle difference in terms of kind of the stage at which the disease is progressing. And then mucinous cystadenocardinoma was here for comparison. We're not really going to cover that this evening, but I thought this was a nice illustration. And if you want to go to the article, you can get more information about this differential diagnosis. So I wanted to compare very quickly invasive micropapillary carcinoma. This is really similar only in the sense that it has this term papillary in it. So this is a pseudopapillary, tubulopapillary or morular structures that have this so-called inside-out growth pattern. And so it's important to be sure to communicate to your surgeons that this is a high-grade and high-risk carcinoma. In order to call it pure papillary carcinoma, invasive papillary carcinoma, it should be 90% of the lesion has that pattern. But if you have a lesser percentage, even 10% or 20%, it does merit attention because it tends to influence the behavior. And these, as I said, have an adverse outcome. Over 40% of them have positive lymph nodes at the time of presentation. And then I'll illustrate this hormone receptor pattern, or excuse me, the ECAD and P120 pattern of staining, which is quite interesting. So here's a needle core biopsy. And as you can see, this doesn't look like a papillary lesion on a needle core biopsy. It looks like an invasive carcinoma. And as we come into higher magnification, I think you can see that it's these very small micropapillary nested pattern with a clear space. This is the so-called inverted pattern, where the luminal surface is sort of out towards the stroma. And that's illustrated or demonstrated with the staining that we'll see here in another second. Here is the invasive component of this tumor. And as you can see, again, it doesn't look like the low-grade papillary carcinoma, the encapsulated papillary carcinoma that we've been talking about. This looks like a very aggressive high-grade tumor. And it's highlighted because you have all of these clear spaces around the epithelial structures. Now, we see patterns like this in other invasive tumors in other organs, sometimes in the ovary with some serous carcinomas with microinvasion will have a micropapillary pattern. But you can see this sort of clear space around the cells is very characteristic. This is not an artifact. This is a part of the way the tumor is behaving. And this is what demonstrates that is this so-called inverted cup staining. Now, what does that mean? Well, if you think of the cup that holds your tea, it has an open top and a solid circle around it. And that's what these cells are doing, is that the surface, the lumina, is the non-staining part, and then the sides and base of the lesion are staining with the marker. As you can see, all of these cells nicely demonstrate that pattern. And so when you see it sort of standing up like that, it's called the inverted cup pattern. And this will be seen with P120 or ECAD, other markers of the membrane, cadherin component. Now, there also are some metastatic tumors that have papillary architecture that can involve the breast. And I thought it would be important to just mention these real quickly. Here is an example of, I believe this is ovarian cancer. It has a little bit of a papillary pattern. It's not the inverted pattern. You can see they're very high-grade nuclei. These cells would be P53 positive. They would probably be estrogen receptor negative, HER2 negative. They would appear like triple negative breast cancer, but in fact, it's metastatic ovarian cancer. And so you have to be aware of those possibilities that you could be dealing with something other than primary breast cancer that has a high-grade papillary pattern. Certainly the patient history can be very helpful. Now, one problem here, of course, is that many of these patients with ovarian serous carcinoma or BRCA, they have the propensity for breast cancers. And so if they're a BRCA1 or 2 deficient patient, they may get a primary breast cancer as well as serous carcinoma. And sometimes distinguishing those two can be very difficult. PAX8 may help, as can sometimes GATA3 or BRCA, or excuse me, GCDFP15. Here's another papillary tumor. As you can see, this has nice papillae, very prominent papillary architecture. As we come in and look at this at higher magnification, you can see these are fairly low-grade nuclei. So these cells could very easily look like encapsulated papillary carcinoma, but it's not really an intracystic or encapsulated lesion. This is an infiltrative lesion. Now, there are some clues here, but you might not pick up on these if you weren't really thinking of it. So there's a few intranuclear cytoplasmic inclusions. Here you see a couple over here. Some of these have this pale nuclear orphananii appearance to some degree. This is a patient with metastatic papillary thyroid carcinoma involving the breast. And so you may think this is not going to happen in your institution, but rare things sometimes happen, and you have to know enough to be able to think about that possibility and not just jump to the possibility that it looks like papillary breast carcinoma. I don't know that I have an example of papillary renal cell carcinoma. That has a little different appearance. Let's see if that's what this is here. No, this is another thyroid carcinoma here. So again, you can see the nice papillae forming here. And on a needle biopsy, this could be somewhat disconcerting if you didn't know the history of what the patient had. It would be very uncommon for this to be the primary presentation of a thyroid carcinoma, but having the history and maybe the suggestion of seeing sort of this nuclear pallor and occasional inclusions could steer you to ask the question, along with the colloid-like tissue here. So no doubt this is in the collection of cases because it's a challenging pitfall for us to try to avoid. Well, I think that's all the cases, that all the slides that I have. Yep, I think that's the end of the slides. And we're almost at the end of the hour. So we'll take a few minutes for answering any other questions that you may have that have come up as I've been talking. Does anybody have any questions you want to bring up?
Professor, I have a question about the intraductal papillary papilloma. This lesion has solitary or multifocal lesion of this tumor.
So encapsulated papillary carcinoma is usually
Intraductal papilloma.
intraductal papilloma.
Yes.
Those can be multifocal. Yes, you're exactly right. Those can appear in multiple sites at the same time.
Yes.
Yeah.
And encapsulated papillary carcinoma is solitary.
Right. Encapsulated papillary carcinoma is usually a solitary lesion. Good question. So I'll just mention that this next month is the Christmas vacation, the Christmas holidays in the United States. And I'm not completely sure what my schedule is going to be to allow this. So I would suggest that maybe we plan for the very first week in January, rather than to try to fit it in before Christmas or after Christmas, but the first week of the new year. And then we can do 2 in January if that's acceptable and we're not too close to your holiday of Lunar New Year.
Yes, of course. Thank you.
Okay. All right, very good. Well, thank you all so much for joining me tonight, and I'll post the recording so that you can look at these things again. And hope you have a very happy day. Work hard and take good care of your patients. We'll see you next time.
Thank you.